Hello and welcome to our talk on bundle branch blocks. Today you're going to learn how to identify and differentiate bundle branch block patterns on the 12-lead EKG. And more importantly than that, why we care, why we need to know that. What does that mean in terms of our patients? And what does it indicate for patients, say, for example, that are coming in with acute myocardial infarction? So, without further ado, I'm going to move on to the next slide, but I want you to know that I'm going to go ahead and eliminate myself from the slides so I don't get in the middle of what you're trying to see on the slides as we move. So, I am taking my face off the slides. I welcome you. I'm so glad you're here, but I think I will be a big distractor in you trying to be able to see the EKGs. So without further ado, let's move on. So let's start out with talking about and just kind of making our way through the normal pathway of conduction. And please know that as we do this, I don't mean to insult anyone's intelligence. I just think that when we're talking about EKGs, it's important for everybody to have a common baseline. So maybe you're an expert already at EKGs, or maybe you're just learning. Either way, we're going to start out with the normal pathway of electrical flow through the conduction system. And as we know, the normal pacemaker of the heart is the sinoatrial node or the SA node. And it's really the normal pacemaker of the heart because it fires the fastest. And we know that the heart has this major rule, one of many, that says that whoever or whatever site fires the fastest really takes control of the heart. And the sinus node is set up in such a way that it fires faster normally now. We're talking normally than other places in the heart. So the impulse spreads from the sinus node throughout the atria via what are called the intraatrial pathways, or so sometimes called the internodal, because these pathways connect up the sinus node and the AV node. Here at the level of the AV node, the impulse takes a very brief pause, and that pause actually allows enough time for the atria to contract, right? Because we know we have electrical activity first, then contraction. So we first have the spread of electricity throughout the atria, and then we have atrial contraction, which of course we all call what? We call that atrial kick. Okay, so after the pause at the level of the AV node, the impulse rapidly goes down the bundle of His, and here's where we're talking today, the right and the left bundle branches. Now, what you'll notice, guys, when you look at the bundle branches is you have a right bundle branch and you have a left bundle branch. And the left bundle branch is actually subdivided into two fascicles. We have the anterior superior fascicle, and if you can kind of imagine the anterior superior fascicle coming out and, toward you, and then we have the posterior inferior fascicle of the left bundle branch. So really, if you counted up our fascicles, we have a total of three, correct? We have the right bundle, which is all by itself its own fascicle. And then we have the two fascicles over on the left side, the anterior superior and the posterior inferior fascicle of the left bundle. Today, when we talk about left bundle branch block, we are talking about an entire block of electrical flow down both of these fascicles. Both the anterior and posterior fascicles are blocked. In our upcoming video, we are going to have a little mini course in hemiblock. And when we use the term hemiblock, what we mean is that half or one fascicle of the left bundle is blocked. But for today's purposes, we're going to say that over on that left side there, when we have a left bundle branch block, we mean both fascicles. So with that in mind, the impulse then, after it goes through the bundles right and left, ultimately the impulse will head out toward the Purkinje fibers. And at the level of the Purkinje fibers, that's when we have depolarization of ventricular muscle, and we can anticipate then ventricular contraction. And that's what, of course, the impulses moving throughout the ventricles are going to give us a QRS. And of course, the ventricular contraction is what gives us the pulse to go along with that QRS. Now, when you look at all of these QRS complexes, you have to admit, when we see them clinically, we'll look at all of them and say, oh, there's a bunch of QRSs. But now we have to refine our language a bit. And now we have to take a look at the component parts. The QRS nomenclature is actually the proper term. And be able to take a look at what makes a Q, what makes an R, what makes an S, because all of that is going to matter in several different things having to do with the 12-lead EKG, but certainly when we are identifying and differentiating right from left bundle branch block. So a Q wave is always defined as the first negative deflection of the QRS complex. So if there's no Q wave, no first negative deflection of the QRS, there's no Q wave. So no negative deflection, I should say no initial negative deflection, there's just plain old no Q. Here's an example over here. Here's a QRS complex that the initial deflection off baseline goes up rather than down. So here we don't even have a Q wave. Now we would look at this complex and we'd say, yep, that's a QRS. Yeah, it is. But when you really break it down, it's just one big tall R wave. And that leads me into my next definition. And that is an R wave is any positive complex or positive wave of the QRS. Here in number 2, you see we have just one big tall QRS complex. That's what we would call it, right? But technically it's just an R wave, a tall R wave. Now compare it down here with number 6. Number 6, you can see the initial upstroke here of the R wave totally eliminates the term Q, right? There is no QRS, there is no Q to this QRS complex. There's just an R followed by an S. And look, we even have another terminal R wave here. So we can see that sometimes the QRS complex will contain an additional wave. Sometimes that additional wave might be an upright wave. Sometimes we have an additional S wave. And that leads us into my third definition here, and that is of the S wave. An S wave is a negative deflection in the QRS complex that follows an R. So that's how you can differentiate it from the Q wave of a QRS. We said the Q wave is a negative, in fact, the first negative deflection of the QRS, whereas the S wave is a negative deflection that follows the R. So here you can see we have an R and an S. In this complex here, we see just an R. And let's go back to number 1, and we see what? We see a Q and an R, but no S, just a Q and an R. Remember, a wave, think about the waves on an ocean. The wave is made up really kind of like 2 lines. So when we talk about the Q wave, the wave is all of this. When we talk about an R wave, the wave is all of this. So we really don't have an S, whereas if you look over here, we have no Q, but we just have an R followed by an S wave. So it really becomes significant to be able to pick out these waves on the 12 lead EKG when we start looking at things like infarctions and ischemia, and we start looking at things like bundle branch blocks and hemi blocks. Now you'll notice sometimes when a QRS is described, you can see some lowercase letters and you can see some uppercase letters. And the lowercase and the uppercase, they're designed that way because they really identify the size of the wave. So you can look at this guy right here and you can say, okay, little tiny baby Q and a really tall R. So the way that we would describe this is we would say lowercase q, that's indicating that the wave is very small, and then the R wave, which is really tall, so that would be uppercase. This wave, number 5, is a QS wave. It is entirely 100% negatively deflected. QS, there are no positive components to this wave. Technically, really, looking at it, it's one big gigantic Q wave. But QS is used to determine or to state that the QRS complex is 100% negatively deflected. Then over here in number 6, we have an R, an S, and another R that follows. So this is called an RSR. And whenever there's a duplicate, like there's a duplicate R wave here, then we say that that is an R prime wave, an R prime wave. So a second wave of the same sort, an additional R is going to be referred to as prime. We look at this, and a lot of critical care nurses will look at that and say, that's a rabbit ear shape. Look for the wide QRS with rabbit ears. And what we see with a right bundle branch block, and that's really that configuration there, is that the right rabbit ear is taller than the left rabbit ear. Just saying. Okay, so enough about QRS morphology and appropriate nomenclature. Make sure that you know QRS. Q is first negative deflection. R wave is any positive deflection. S wave is any negative deflection that follows an R. Okay, so I want you, and if you have to pause the video, go ahead and do that for a minute. And I'd like you to just label these waves. So just pause if you'd like and label these waves, and then we'll get back together again. Okay, so looking at this wave right here, I'm sure you got R wave, one big tall R. This wave right here is an R, correct? And an S. There is no Q wave present because the first deflection off baseline goes up. And so there is no Q. Well, then you've got this guy over here where, again, there's no Q wave because the first deflection of the QRS complex goes up. So we have an R wave. This is a what? R, S, R prime configuration. R, S, R prime configuration. And so this is where, in the presence of a wide QRS complex, we say that the patient has what looks like a rabbit ear or right bundle branch block configuration. This big guy here, what we notice about this QRS complex is that there is no R wave whatsoever. This is one big Q wave or merged. You can call it a QS wave. Q merges with the S, indicating that there are no positive deflections of that Q wave. Then last but not least, over here we have what's called a QR. Would you agree with that? because we have a negative deflection and we have a positive deflection, QR. Now look at this guy. We have a Q, we have an R, and then we have an S. So I believe out of all of the complexes, really, even though we would look at this whole screen and say there's a bunch of QRSs, we really only have one that technically has all of the components, the Q, the R, and the S. Now, when we talk about the leads used to identify bundle branch block in the body, okay, or on the EKG, I should say, we use the chest leads for this purpose. Chest leads are very, very helpful. We'll throw in a few limb leads as needed, but really what we want here is we want a right chest lead and we want a left chest lead. So here we have the right chest lead. The right chest lead is V1, whereas the left chest lead is V6. So for now and forevermore, when we refer to looking at a lead on the right side of the chest, we're looking at V1. Left side is V6. So when we talk about those two leads, here is an example of what we're going to be getting into. The first type of bundle branch block we're going to be getting into is talking about a right bundle branch block. And so what we see with a right bundle branch block, you kind of have to think about the fact that you're looking at the heart from two opposite directions. That's why we have one right chest lead and we have one left chest lead. So if you take a look at a right bundle from the viewpoint of V1, from the viewpoint, now keep in mind V1 is looking this way at the heart. What will V1 see? Well, what V1 will see is V1 will see depolarization of the septum, which goes from left to right. It's the left bundle's responsibility to depolarize the septum, and it depolarizes it from left to right. And as that electricity moves from left to right, it initially is producing a positive complex over here in V1. So when we see in V1 that there's a little positive upstroke here, that's depolarization of the septum from left to right. Now remember, we have a right bundle branch block, so impulses cannot go down that right side. Everything goes down the left side. And as it goes down the left side, what we will see is that the impulses are moving what? Impulses are moving away from V1, because what will happen is the left side of the heart will get electricity before the right. And so we will see a S wave followed by the left ventricle. Now over on this left side, now we have electrical impulses that are all headed toward the right, because we've been taught from little on that the heart is an all or none sort of a thing. So you can't just have like one part of the heart that gets electricity and nothing else. You always have that cell to cell to cell transfer of electricity. So the very last part of this process is where impulses are moving from left to right to cover that right side. So once again, looking at it from V1's perspective, what we see is we see all the impulses moving from left to right to catch that right side, cell to cell transfer of electricity. So we have that second rabbit ear, which we call the R prime wave. And because the heart really is being depolarized in what's kind of a lopsided manner, we're going to have a widened QRS complex. And so, that is the basic criteria that we're going to look at that would make us even search out for a bundle branch block, is the fact that the QRS is wide. We can also see a strain pattern over on the right side of the chest, meaning that the T wave can become inverted over on that right side as well. Now take every single thing I said and just flip it over. And then you'll be looking at things from V6's perspective. Because the way V6 looks at things is from the left side of the chest. So look, guys. Here we have what? Septal depolarization from left to right. From V6's point of view, when that septum depolarizes from left to right, that electrical activity is moving away from V6, and so we see a negative deflection. Well, what did we say happens next? We said impulses are headed left, and so we see a big, tall R wave. But then we said the impulses have to be sent back around to the right, cell-to-cell transfer of electricity, which from V6's standpoint is going to give us a very slurred, sloppy-looking S wave over here in V6. And so when we talk about the classic configuration for a right bundle branch block, we see RSR prime configuration in V1, and I have to give you fair warning that sometimes we don't see this lovely, rabbit ear thing, but rather these merge together to create one very tall, wide complex, upwardly deflected complex in V1. And V1 should never, not ever be normally a tall upright complex. And then so we have RSR prime in V1 and we have QR slurred S in V6. That is the classic right bundle branch block pattern. So everything I just said to you is plotted out on this slide with all of the words to go along with it. First, the septum depolarizes from left to right, continues on, depolarizes the left side of the heart, then impulses have to head right, which will make the QRS complex wide because it takes longer for all of the ventricular tissue to get electricity before contracting. And that is what is going to widen your QRS. Okay, so again, when we are looking for a right bundle branch block, we look for an R or an R prime wave, RSR prime. We look in V1 and his neighbor V2, whereas over in V5, V6, with V6 being the leftmost lead, we see small q, R, and you see a slurring of the S wave in V6. And since the positive pole of lead 1 is over on that lateral side, it's over on the left arm, it also looks at the left lateral side of the heart. So you can see that slurred S even over in lead 1. So here is our classic RSR prime configuration. And as you can see from this tracing here, we are in V1. You'll notice that this patient also is in sinus rhythm. So we have sinus rhythm with a right bundle branch block. And we know it's a right bundle branch block because you look at, first of all, the width of the QRS complex to determine that there's a bundle branch block. So is the width of the QRS complex 0.12 or greater? And yes, check, we're there, roger that. And then we look at the configuration in V1 to determine if it's left or right. And we can certainly see here RSR prime configuration and right ventricular strain pattern, which is causing the tipped over T. Okay, so when we talk about a right bundle branch block, it really limits our ability to diagnose right ventricular hypertrophy. And by the way, there is going to be coming out another little video mini course, accredited CE course on identifying chamber hypertrophy on the 12-lead ECG, which includes both atrial and ventricular hypertrophy. And it's also true that a left bundle branch block severely limits the ability to diagnose left ventricular hypertrophy, and it also really can limit our ability to identify ST segment elevation. So let's get into then talking about left bundle branch block. And here we have, I think it's really easier, of the two bundle branch blocks. I think picking up on a left bundle is easier, I think, than a right bundle branch block. And you'll see why in just a second. So what we see with a left bundle branch block is that impulses can't make it down to the left bundle. The septum doesn't even get depolarized normally. Impulses head down the right bundle only. Right side of the heart gets depolarized, and then impulses are all sent left. So when we take a look at V1 and V6, again, our right chest lead and our left chest lead, what we wind up seeing is this big, huge, negatively deflected complex in V1. Sometimes you can see this itty bitty baby R here in V1. And by the way, that does not represent septal depolarization. That little itty bitty baby R there represents activation of the right ventricle. And then all impulses are sent left. And keep in mind, over here in V1, we're looking at it from the V1's point of view. So it looks at the right side of the heart. So when all impulses after right ventricular activation, all impulses are sent left, you can see why we wind up with this big negatively deflected complex. So we have RS. Over in V6, take a look at what happens here. We have one big tall R, and this R very commonly looks like an M. Okay, it looks like an M. It doesn't have to, but it very commonly has a notch in it. It's wide. It's over in V6 looking at the left side, and we also have a strain pattern with a flipped over T wave over there in V6. And so this is an example of what the QRS complex would look like in a left bundle branch block comparing V1 through V1 to V6. So when we take a look at the characteristics of a left bundle, now look down here, V6 looks right at that left side. And so we can see here that this patient is in sinus rhythm, is he not? But you look at the QRS complex and you've got this big, wide QRS, no doubt about that, that's too big. And then you have the QRS that looks like an M in V6, and sometimes you'll honestly see what looks like a W in V1. Keep in mind they're opposites, right? Because they're looking at opposite sides of the chest. V6 is looking at the left side of the chest. V1 is looking at the right side of the chest. So here's the EKG of a patient with a left bundle branch block. And so we're going to hone in on our right and left chest leads. So we see V1 and V6. Is this patient in sinus rhythm? Yeah, patient's in sinus rhythm. You see an upright P wave in front of the QRSs. So as far as I know, I'm going to say sinus rhythm there. And then over here in V1, we see a small little R representing a right ventricular activation, and then a big, huge, wide, negatively deflected QRS. That's a left bundle. Now compare it to V6. There's your M, right? Sinus rhythm, big, tall, wide M over in V6. And you can also see over in lead 1, again, lead 1 also looks on that left lateral side, and you can see that over in lead 1 as well. Sinus rhythm, but with a big, wide QRS complex. And then, of course, you can see the left ventricular strain pattern, which is that tipped over T wave. So comparing the two, here you have leads 1, lead 6. Here we have a right bundle branch block. So in V1, we're going to have RSR prime configuration. Over in V6 and lead 1, we're going to have QR slurred sloppy S wave. Left bundle branch block, what are we going to have? We're going to have big, wide, positively deflected complex in lead 1 and also in V6. And then over here in V1, we're going to have a big, wide, negatively deflected complex over in V1. And here, this complex is actually a QS. Oftentimes, that activation of the right ventricle gets lost. So you see here that activation of the right ventricle is lost because right ventricular activation would have produced a little itty bitty tiny R, and no, we don't see it here. But it is one of the criteria that you may see, either a big old QS or a small little tiny R with a deep S wave. Okay, so I would like your thoughts on this one. And I'm going to tell you right now that the lead that we're looking at is the chest lead. We're looking at V1. And what I'd like to know from you is A, are we in sinus rhythm? And B, is there a bundle branch block? If there's a bundle branch block, then what kind of bundle branch block are we talking about here? Okay, so I gave you a moment to think about that, and I didn't mean to purposely try and trip you up. But yes, we're in sinus rhythm, but look at the width of the QRS complex. So you've kind of got to go to where the QRS kind of bends. The QRS complex, really, in this example here, is not wide enough. You see where the QRS comes up and then bends into the ST&T? This is the end of the QRS here. This QRS is 0.08 to 0.10. So has this little itty bitty piece of a rhythm strip, does it give you the criteria for a bundle branch block? To even look for a bundle branch block? I hope your answer is no. Because the basic criteria to make you search for a bundle branch block is that the QRS needs to be wide. So I just wanted to make sure that we could all pick up on normal width versus wide width in terms of what would make us look for a bundle branch block. All right, now let's get into some ECGs here. For each one of these, I would recommend that you take a moment and you pause the recording and just kind of take a look at this and get your own clinical impressions first, and then, resume the play so we can go from there. I'm going to pause for just a little bit, but if you need more time, please press pause. And so my two questions remain the same, and that is the patient in sinus rhythm, number one? And number two, is there a bundle branch block pattern visible to you? And if so, what kind of bundle branch block does this patient have? Take a moment and look this over. Okay, so first of all, when you have a 12 lead EKG that prints out this beautiful rhythm strip on the bottom, it's always a good place to start because the rhythm strip on the bottom is typically in lead 2. Sometimes the V lead will also be added down here, but it's really nice because it gives you a real long strip of the patient's rhythm, which we know here to be sinus. Okay, so this patient is in sinus rhythm. Now, let's go up and look at the width of the QRS. My eyes first go to V1 and V6. And I can see pretty quickly looking at V1 that QRS complex is wide. So I'm going to be searching for a bundle branch block, am I not? I am definitely searching for a bundle branch block. And so I'm seeing that this QRS is minimally 0.12 to 0.14 seconds. I am then looking at V1 and I'm looking at the configuration. And I'm seeing a huge, deeply deflected QRS complex, negatively deflected. And so I know that if it was a right bundle branch block in V1, I would have something that looks positive and RSR prime-ish. I don't have that. I have this big negatively deflected complex. This is a left bundle branch block. And when I look over in V6, V6 looks really sloppy in terms of, not this really great M shape, that you can see real well. But you can see that it's definitely wide over here in V6. It's definitely upright, but it certainly doesn't give you the classic shape of the M pattern. But it is indeed, sometimes we have to apply the criteria that we have, and we have enough criteria with the wide QRS, the deeply inverted QS in V1. We have the criteria that we need to call this thing a left bundle branch block. Take a moment and look this one over. My questions remain the same. Pause if you need to. Okay, when we look at the bottom, we can see in lead 2 here running along the bottom, we can see a P in front of the QRSs. Not a super duper lovely looking P, but it's there. We have a P in front of every QRS. Then we go up and our eyes shift to the right and left chest leads. So we go right for V1 and left chest lead is V6. So we see that our QRS complex is a little bit at or more than 0.12. And then when we look at the configuration in V1, what do we see? We see small little r, s, and then another r, which we call r prime configuration. So r, s, r prime configuration. And then over in V6, what do we see? We see an R slurred S. And you really want to see a slur? Look at V6's friend over here, lead 1. We see R, and then there's a slurred S wave. You can see it right here. So what this winds up to be then is a right bundle branch block pattern. How are you doing? Okay, here's another one for us to take a look at. Okay, so we're going to start out with our rhythm. What is our patient in? Looking along the bottom of the EKG here, we have lead 2, and we have a pretty good looking sinus rhythm here, right? So we have a P in front of the QRS complexes, And then our eyes go up and check out V1. And V1 definitely looks like a wide QRS starting here. And the bend of the QRS, I always call it, the J point. That's not my term. That is an accepted term. The J point is the actual junction point between the QRS and the ST segment. I have my laser on it right now. That is the J point, the junction point. So all of this is QRS. The QRS complex looks like 0.16 to 0.18. It's a big QRS. So that then would make us look for a bundle branch block. Would it not? That would definitely make us look for a bundle branch block. And so we look at the configuration of the QRS complex in V1, and we see that this patient has RSR prime configuration in V1. Widen QRS got us started. Then we went to RSR prime configuration in V1, and then V6. Okay, we see R, I don't know, is that a slurred S? If you have any questions, head over to V6's partner over here, and that's lead 1. And so in lead 1, you can certainly see the tall R, the slurred sloppy S at the end, and yes, indeed, you have a right bundle branch block here. Take a moment and look this one over. Okay, so it looks like we don't have that nice, beautiful rhythm strip to work with, but it certainly looks like this patient's mechanism that's running the heart is the sinus mechanism, right? So we have sinus rhythm. And then if you take a look at these QRS complexes, the QRS complexes are wide, yes? So you take a look and, gee, the QRS complex is easily 0.18, give or take. So we know we're looking at sinus rhythm with some sort of bundle branch block. So we look at our right and left chest leads. Over on the right, we look at V1. Over on the left, we look at, well, it doesn't look like here we go. Sorry about that. V6, which again doesn't really have this really wonderful shape to it. We can look at his next door neighbor, which is V5, and we see what? We see an M type of appearance. Over here we see right ventricular activation and a huge, in V1, a huge S wave, wide S wave. Now what we've got going on here, look at those little blue markings there. We can see ST segment elevation. So it looks like we have left bundle branch block according to the configuration of the QRSs in V1 and V6 in the face of an ST elevation MI, in the face of a STEMI, right? And so we know that when a patient has ST elevation and a STEMI and develops a bundle branch block in the face of an MI, we're talking about a pretty extensive anterior lateral MI, and that patient's mortality rate climbs. And so we have to be very concerned about that, obviously. So it looks like in this EKG, we've got some pretty major issues going on, the ST elevation along with the left bundle branch block. Now, I don't know whether this bundle branch block is old, so the patient has had it for however long, or it is new in the face of this MI. And if it's new, again, mortality rate goes up, heart failure, lethal dysrhythmias, the need for pacing, all of that increases. Here's another EKG. Take a moment and look this one over. Okay, we can all appreciate the fact that when you look at V1, here's the bend of the QRS complex into the ST segment. You can see here that this most definitely is a widened QRS. And so that's going to cause us to look for a bundle branch block, right? And differentiate the bundle branch block. Down here at the bottom, we can look at the rhythm strip on the bottom and we can say, okay, I know this patient is in sinus rhythm. And so sinus rhythm with, well, let's look at the shape of the QRS complex in V1 and V6. Now, this really helps us out a lot, right? Because, you look over at V6 and you see like the M there over in V6. And over in V1, you see this very negatively deflected S wave there. There might be ever so slightly, can't really swear to it, whether there's a little tiny R. I have a tendency to say no. Either way, big negatively deflected S wave consistent with left bundle branch block pattern. So that's what we have going on here. Left bundle branch block pattern. Now, sometimes you hear terms like rate dependent bundle branch block, rate dependent bundle branch block. And what you see is that as the person has a given heart rate and then the heart rate speeds up, the person's still in sinus, but the heart rate speeds up. When you see an intermittent or rate related or rate dependent bundle branch block, what happens is that when the rate speeds up, it actually kind of catches the bundle, one bundle or the other, in its refractory period. So at that moment, it doesn't respond. So we're looking at a V1 tracing, a chest tracing here. And you can see this person is clipping along, normal day in sinus rhythm. QRS looks great. And all of a sudden the rate speeds up, does it not? And so the person still in sinus still has the P waves in front of the QRSs, but you'll notice that the QRS widens out. And the patient has developed a left bundle branch block configuration. So this patient has sinus rhythm with a rate-related left bundle branch block. So every time he picks up his rate, he develops an intermittent bundle branch block during that rate change. And you see that a lot of times in the elderly. All right, so we see then, like I said, how it happens is that one of the bundles is caught in its refractory time, whether it's the right or the left bundle branch is caught in its refractory period and it's not able to conduct. And so depending upon the bundle that can conduct, that is going to have an influence on what kind of configuration the QRS will have and what kind of rate related bundle you'll have. So take a moment and look this one over. I'd like to have you look at this independently. And then we'll go on. Okay, most of the time this patient's in a sinus rhythm, yes? Sinus rhythm. And then it looks like the patient's heart rate speeds up a little bit, not a ton, but if you were to take your calipers, you can just eyeball it. It doesn't take a calipers to show you, but you can go from here to here, measure that out, and notice when you bring your calipers over, this beat comes in early. Still, all along the way, the patient is still in sinus rhythm. But now in V1, which is the lead that we're looking at here, in V1, we see an RSR prime configuration, RSR prime. We also see the T wave tip over, which is a right ventricular strain pattern. And so RSR prime in V1, this patient is in sinus with a what? Rate related right bundle branch block. The RSR prime tells us that it is the right bundle, and this is the one that's most common. So when people develop a rate-related bundle branch block, it's usually a right bundle branch block. In fact, in atrial fibrillation, we oftentimes see this where the rate speeds up, and we intermittently will see an RSR prime configuration. We know that to be what? Ashman's phenomenon. And that's just basically the right bundle being caught in its refractory period where it cannot respond. So it registers then on the EKG as a right bundle branch block pattern. All right. Take a moment and check it out. Okay, so what rhythm is this patient in? This patient, it looks like the majority of the time, I don't know if it's really majority, I don't have a lot to work with in terms of a rhythm strip, but the patient is in sinus rhythm, right? When you look at, here's a P and a QRS of a normal width, but look what happens here. The patient's rate speeds up, and when the patient's rate speeds up, the QRS widens out. And when we look up here at V1, when the rate speeds up and the QRS widens out, it has a left bundle branch block pattern over here in V1 compared to the normal QRS here, a rate-related left bundle branch block. Then there's another term that's used, and this doesn't happen as much as the pickup in heart rate, but rather here we're talking about a Brady-dependent bundle branch block, where we find that because the patient slows down, they develop an intermittent bundle branch block. And so if this was the chest lead, so V1, this would be a Brady-dependent right bundle. Yes, it does not have the RSR prime, but it's positively deflected, very tall and positively deflected in V1. There's not as much understood about why this occurs with a Brady, except for the fact that it's probably related to ischemia. Ischemia due to the drop in heart rate, and the ischemia is what's causing the intermittent bundle branch block. And in this case, in V1, which is what we're looking at here, an intermittent right bundle branch block. And then it's like the bundles rally and the patient goes back to the normal configuration again. Okay, so here's another example. You can see another example here where patient, slows down and the resulting complex, then you can see it here, becomes wide. So if this were a V1 tracing, for example, that would be a RSR prime configuration. But this actually is, looking across the chest leads. And so this is V6. So we're looking across the chest leads and we see a big M, right? So V1, V2, V3, V4, V5, V6, big tall M. So this is a Brady-dependent left bundle branch block. And it's just intermittent because notice this patient goes right back to their normal width QRS complex after the bundle regenerates, if you will. Well, thank you everyone for being here today. I enjoyed this time together. And so I have a lot of things coming up. Next, there will be determination of axis on the 12-lead EKG, why we care, why it matters. And then we're going to get into fascicular block. And then we're going to look at chamber hypertrophy, atrial and ventricular hypertrophy, and identifying it on the 12-lead EKG. Thank you so much for being with me today and following through to the end. Bye-bye. Take care.